Hello and welcome to our listeners around the world. This is the JAMA Editor Summary, and today is Friday, March 7, 2025. I'm Dr. Linda Brubaker, Deputy Editor at JAMA, sitting in for the Editor-in-Chief of JAMA, Dr. Kirsten Bibbins-Domingo. I'm joined today by JAMA Deputy Editor Dr. Preeti Malani. Hi, Preeti. Let's get started.
Hi, Linda. JAMA published a cross-sectional study evaluating protein S variants in participants from the UK Biobank and the U.S. National Institutes of Health All of Us program. The study used participants' whole exome sequencing to evaluate the presence of germline variants for protein S and whether these variations could affect total protein S levels or the risk of venous thromboembolism. The researchers reported that heterozygosity for the highest risk variants, PROS1 variants, was associated with an increased risk for thrombosis and resulted in a low protein S level. In contrast, some lower risk variants had more marginally reduced protein S concentrations and a relatively lower risk of thrombosis.
In the accompanying editorial by Dr. Ragni, she reviews what protein S deficiency is and explains that this study helps illuminate the severity of PROS1 variants.
JAMA and JAMA Cardiology published a content collection this week on coronary artery calcium scoring. Dr. Narelkar and colleagues conducted a randomized clinical trial that investigated the utility of communicating coronary artery calcium, or CAC scores, to patients. The study included 365 asymptomatic patients who had a family history of coronary artery disease and a CAC score greater than 0 and up to 400. Patients were randomly assigned into two groups. The intervention group received a nurse-based intervention that communicated CAC findings to the participants, along with usual care counseling, as well as the initiation of atorvastatin. The control group received usual care with statin therapy initiated as needed. For their primary outcome, researchers reported a 24.9 millimeters cubed change in total plaque volume in the usual care group and a 15.4 millimeters cubed mean change in total plaque volume in the CAC score informed group, for a mean difference in change of 9.5 millimeters cubed. The authors concluded that the intervention group in which CAC scores were shared had slower plaque progression at the 3-year mark compared with the usual care group. The CAC score group was also associated with a reduction of lipids.
In an associated JAMA author interview podcast, JAMA Associate Editor Pradeep Natarajan spoke with co-author Tom Marwick of the Baker Heart and Diabetes Institute in Melbourne, Australia. Here's a clip from that interview.
Well, I hope we get to a situation where we're using the total plaque volume more widely than we are at the moment. So I think we're sort of halfway there in terms of using coronary artery calcium, but we could have much more granular information from looking at the total plaque volume. So I see that as a potential area of growth. I think at the moment, sometimes patients get a CT coronary angiogram in a primary prevention setting, but it's not in the guidelines. And maybe that's something that will grow in the future as we learn more about the additional prognostic information. And I think for us, and maybe this is specific to Australia, I'm not sure, but we don't have a reimbursement profile for CAC at the moment. And it means that the people who are most at risk, may not be able to afford this. And I think as we demonstrated here, it's a very informative piece of data in terms of guiding treatment and also changing patient behavior.
And Dr. Nasir and Blankstein contributed an editorial. They commend the author's focus on subclinical coronary atherosclerosis and their patient-centered approach. They also point out that the study showed greater benefits for patients with CAC scores greater than 100. They hypothesized that this could be helpful in establishing a threshold for individuals most likely to benefit from this approach. JAMA also published an Insights article about cardiac CT calcium scoring by Dr. Glynn and colleagues, in which they review CAC scores in depth and how they can predict future adverse cardiovascular events in patients.
JAMA published 2 research letters this week. Dr. Spinelli and colleagues evaluated HIV viral suppression using long-acting antiretroviral therapy in individuals diagnosed with HIV who received long-acting antiretroviral therapy from San Francisco's Ward 86 HIV clinic. Researchers compared the viral load in patients with and without viremia at 48 weeks after starting long-acting antiretroviral therapy. They reported at 48 weeks, 98% of patients with initial viremia had undetectable viral loads, compared with 99% of individuals without viremia. The authors concluded that viral suppression with the use of long-acting antiretroviral therapy at 48 weeks was high and did not differ among individuals with or without baseline viremia.
Jessica Starr and colleagues investigated whether the COVID-19 pandemic impacted breast, colorectal, and cervical cancer screening in the U.S., using data from the National Health Interview Survey from 2019 to 2023. The authors reported that in 2023, breast and colon cancer screening recovered from the pandemic declines and surpassed pre-pandemic screening estimates. However, 2023 cervical cancer screening rates were below pre-pandemic levels.
JAMA published 2 viewpoints this week. Doctors McDermott and Chella wrote a viewpoint this week on peripheral artery disease, or PAD. They speculate that patients with PAD underreport their walking difficulty, as shown in recent clinical trials, leading to clinical underappreciation of symptoms. The authors propose both objective and patient-centered methods when caring for patients with PAD. In another viewpoint, Dr. Walensky and colleagues talk about the importance of physician social scientists. Physician social scientists are trained in medicine, social sciences, and humanities, and hone unique interdisciplinary skills during their training. The authors discuss ways to support these individuals at the local and national levels.
JAMA published a perspective article by Dr. Lipnick and colleagues in which they discussed the FDA's 2025 guidance on pulse oximetry and skin pigmentation, which aims to reduce disparities in device performance related to skin pigment. The authors review the strengths and weaknesses of this new guidance. Drs. Lipnick and Bickler joined JAMA executive editor Dr. Gregory Kerfman on the JAMA Author Interview podcast to discuss the article. Let's listen to a bit of their discussion.
In the new 2025 draft guidance, FDA recommends measuring skin color in 2 ways. The first is using the Monk Skin Tone Scale, which is the only standardized 10 color scales that was designed specifically with diversity of human skin color in mind. And the second is using a spectrophotometer to actually measure the color of the skin. It's like if you went to the hardware store to match a paint color. Color can be quantified. There are a number of devices out there that can do this for skin. And while there is no complete consensus on the method, a widely used and validated approach is the use of what's called the ITA, which is an established surrogate for melanin. Using these methods, a new guidance recommends ensuring the proportion of participants that are light, medium, and dark is more equally distributed than the prior guidance, where only 2 of 10 study participants were recommended to be darkly pigmented. So it encompasses the full range of human skin pigmentation.
There's also a JAMA clinical review with related podcast about eating disorders. Doctors Attia and Walsh reviewed 79 articles to synthesize clinical features and appropriate treatment for anorexia nervosa, bulimia nervosa, binge eating disorder, and avoidant restrictive food intake disorder, or ARFID. In the Associated JAMA Clinical Reviews podcast, JAMA Deputy Editor Dr. Kristen Walter interviews Dr. Attia and Walsh.
Drs. Lee and Elmore provide guidance for clinicians on breast imaging counseling for patients with dense breasts. This comes after the FDA recently mandated breast density reporting on mammography results. The authors offer key points and supplemental screening guidance in their JAMA Insights article.
Freelance journalist and pediatrician Dr. Kahan reports on the U.S. Department of Justice's lawsuit involving CVS and Walgreens. The DOJ claims that pharmacies filled illegitimate opioid prescriptions and then requested reimbursement from Medicare and Medicaid for these prescriptions. Dr. Roy Perlis, editor-in-chief of JAMA Plus AI, interviews Dr. Ostergaard about his work with machine learning models and mental health. They talk about how this technology might be used to identify high-risk mental health disorders like schizophrenia and bipolar disorder when patients present to Denmark's psychiatric service system. Here's a clip from the JAMA Plus AI Conversations podcast interview.
We see consistently in health records, at least in psychiatry, but I think more generally, that someone builds a model, the model performs reasonably well, but the conclusion is, we're not there yet. This is promising, but we need to do more. And I guess I would put to you the question, what actually do we need to be doing? Is it better models? Will better machine learning solve this problem? Is it other things in the health record that we're not incorporating? Or are we just not measuring the things that we need to measure to really build clinical models from health records or registry data that will be performant enough to be deployed? The good news is nobody knows the answer to this, or at least nobody knows it yet. What tact are you guys taking? What do you think?
Probably a bit of both. Having better methods and more sophisticated hardware will probably help. And including more data may also help. Not necessarily that the data has to be informative. Otherwise, it will probably have the opposite effect in terms of prediction. And I actually think that maybe not for this particular model because the prediction level is pretty far from perfect, but with some of the other models we have developed, I actually think that they're sufficiently accurate to be deployed in clinical practice.
Thanks for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo. This episode was produced by Daniel Morrow, Shelley Steffens, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.